opportunity. So, I'm Segal, I'm a pediatric neurologist, and today I want to present my study on the orthotic effect and functional benefit of dorsiflexion FES in children with hemiplegic CP. So, children with hemiplegic CP are at greater risk of instability and falling due to insufficient foot clearance during the swing and abnormal foot contact in the stance. And most of these children are prescribed with AFOs, which we know that have many known advantages, but still they have some major disadvantages. They are cumbersome, they require certain shoes, they may affect body image, which may influence the compliance. And in addition, the disuse of the muscle may exacerbate the muscle weakness and atrophy. FES, functional electrical stimulation device, is today a well-known neuroprosthesis. And during walking, it delivers electrical stimulation to the motor nerve and activates the desired muscle group. The dorsiflexion FES stimulates the common peroneal nerve and activates the ankle dorsiflexors in order to correct the upper motor neuron foot drop. The device is in small size, easy to use, and has the option to use with any shoe or even barefoot. And this factor can increase the compliance. In addition, the activity of the muscle may prevent the muscle atrophy. So although the application of the dorsiflexion FES with the CP population is still limited, yet studies have found a good acceptability and a consistent evidence for improvement in kinematic parameters, which is commonly called the orthotic effect. Despite this, there are no defined parameters which could predict the response to this kind of intervention in a specific patient. In addition, the presence and the extent of the functional benefit and the function and the therapeutic effect, which means the effect while the patient is no longer using this device, is still inconclusive. So the aim of this study was firstly to evaluate the orthotic effect, namely whether this device could correct the drop foot and could serve as an alternative to regular A4, and to identify parameters which could predict the orthotic effect in children with hemiplegic CP. In addition, the study aimed to evaluate the motor functional benefit and the immediate therapeutic effect after 5 months of continuous use. This study was conducted at the Pediatric Neurology Unit of Tel Aviv Medical Hospital with the cooperation of the Gait Analysis Laboratory. And we included high-functioning hemiplegic CP children above 6 years of age without a fixed contracture of the ankle, which means that there was at least 0 degree of ankle dorsiflexion in a passive range of motion test. And in this study, we used the walk-aid device. This device sits on a cuff beneath the knee and stimulates the common peroneal nerve by a tilt sensor, which senses the motion of the leg moving forward, and it could also be used when barefoot. Because it stimulates the common peroneal nerve, it produces not only dorsiflexion, but also an aversion. This was a prospective open-label study which was divided to 2 periods, 1 month of adaptation and 4 months of continuous use. And during this period, patient underwent a repeated assessment, including physical tests, motor functional tests, fallen questionnaires, and 2 examinations of gait analysis, 1 at the end of adaptation and 1 at the final assessment. And the motor functional test included the community balance and mobility scale, the 6-minute walk, the times up, downstairs, and those tests were performed when FES was both on and off. In this study, we defined significant orthotic effect not just by an improvement in kinematic parameters, but rather by a significant change in the position of the ankle from negative to positive angle while using the FES either at the mid swing or the terminal swing, as you can see here at the left graph. And we compared the demographic, the physical, and the clinical parameters of those with significant effect and those without
significant effect. 26 patients started the adaptation, 22 finished the adaptation and performed the first gate analysis, and 15 patients completed the study. These are the features of our study group with a median age around 8 years, most of them GMFCS 1. And in the first gate analysis, we could see significant improvement in kinematic parameters, but you can see that there is a large variation of the effect among patients. Taking the 22 patients, we could see that they were divided equally to two subgroups. 11 patients had significant effect, and other 11 patients had no significant effect. It should be noted also that we noticed that the significant effect was demonstrated specifically during the terminal swing, and only the minority also at the mid-swing. Comparing the demographic variables, we couldn't find any significant difference between the two subgroups, but comparing the physical variables, although the passive ankle range of motion was not statistically different, if we are taking the dorsiflexion at the mid-stance, we could see that those without significant effect had much less dorsiflexion compared to those with significant effect. What happened after the first gate analysis? So 7 patients drop out, most of them because of inefficacy. And of the 15 patients who completed the second gate analysis, 12 had significant effect and 3 had no significant effect. It should be noted also that 2 patients gained significant effect and 1 patient lost the effect in the second gate analysis. And in this patient, his ankle range of motion decreased at the last assessment. In addition, in 80% of the cases, relating to the orthotic effect, the initial and the final results were similar. What happened in the functional aspects? So considering the falling questionnaires, we could see significant decrease in falling at the last assessment. And in a repeated measurements, we could see that over time, there was a significant increase in balance score when those patients tested with FES on and also when FES was off. In the 6-minute walk, we could see that those patients walked shorter distance, again, when FES was on and also off, what could suggest a slower walking. So to conclude, Kamis, in his review, stated that there are no defined parameters for using the FES, but still, a prerequisite is the ability to maintain adequate passive range of motion. And different studies use different inclusion criteria. Some included only patients above 5 degrees of dorsiflexion, some included also patients above 0 degree of dorsiflexion. And our findings suggest that significant effect is indeed dependent on range of motion, but it should be measured not by passive measures, but rather by weight-bearing measures or even a dynamic measures like the dorsiflexion in the mid-stance. We could also see functional benefit with less falling and increasing balance score, but with indication for slow walking. And the results regarding the walking speed with FES are still conflicting in the literature. And our finding of slow walking may be the results of a more controlled gait pattern. Is there any evidence in our study regarding the therapeutic effect? So on the one hand, there was no significant change in the range of motion, in the spasticity score, in the muscle strength. But on the other hand, there was improvement in balance score even when FES was off. And it may imply that there is some central influence to this device, maybe by enhanced motor learning over time. In most of the cases, we could determine the final results already after a very short time of adaptation, but still there is some risk for instability of the effect. So even in those with significant effect, they should be in a close follow-up to make sure the effect is not losing. Our main limitation is small study group and the absence of a control study.
Go to the conclusion, please.
Excuse me?
Time. Conclusion.
Okay. And there is need for a larger case control studies with long-term outcomes and a direct comparison to regular reform. Thank you.
Any questions?